Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
Well, welcome everybody to the Learning Collaborative session through the Tennessee Heart Health Network. As Gladys mentioned, I'm a staff physician at Harvard Justice. So what I want to do is spend a little bit of time going over some causes of high blood pressure that are less known among the non-medical community, but which patients work on at home and which can have a significant effect on blood pressure. So, let's see here. Oh, there we go. All right. Well, so I want to spend, I want to emphasize that if many of these factors apply to you, each can have a small contribution to your blood pressure. So if you work on all those factors that apply to you, you could have a large drop in your blood pressure. And so, and also I want to spend some time going over the mechanisms of how each of these factors result in blood pressure. Quite often when we know the why, we can then make changes in lifestyle. So we're going to start. First, we'll talk briefly about the importance of measuring blood pressure at home and getting good information for your physician. The reason for that is that sometimes there's a mismatch between your home blood pressures and office blood pressures. And so when your blood pressure in the office is higher than at home, that's called white coat hypertension. And the reverse, when the blood pressure is higher at home but normal in the office, that's called masked hypertension. So if you can generate dependable readings and your doctor can see that there's a mismatch, your doctor could avoid over-treating you or possibly under-treating you. So just a brief review. Just make sure that when you check your blood pressure, you're not stressed out, you haven't had coffee or exercise or smoked in the previous 30 minutes, and that you're sitting down calmly for at least 5 minutes. And that when you check your blood pressure cuff, it should be the level of your breastplate in the middle. So avoid keeping your blood pressure very high or very low when you need your blood pressure. That way you can generate high quality blood pressures for your to help out your doctor. So we'll start here with obesity. I think it's a good place to start because remarkably, this is the cause of a majority of blood pressure cases, at least in the United States. And so a way that we quantify obesity is the BMI. There are other tools, as I mentioned here, the waist-to-hip ratio and others. And so anything above a BMI of 30 requires a little closer inspection by the patient and also the physician. Now, the BMI is not a perfect indicator of fat composition because it doesn't comment on where the fat is distributed. And that's significant because patients who have a lot of intra-abdominal fat, that's fat in the abdominal cavity, also called visceral fat, they tend to have higher blood pressures than the fat that's distributed along the hips and legs. And so one way to screen for that would be to calculate, just measure your ratio or the circumference of your waist to your hips. And so for in men, anything above 1 and anything above 0.5 in women requires a little further work, either on the patient's behalf or with help of a physician. That way you can screen for what so-called apple body that it has higher risks of elevated blood pressure. So as I said before, I wanted to spend some time going over the why, so that this could propel patients to make these lifestyle changes. So when visceral fat starts increasing in the abdominal cavity, it'll literally compress the kidneys. And so the kidneys will feel less blood flow. And in order to compensate for that, the kidneys will release hormones to increase the blood pressure. And then as the amount of proportion of fat increases in the tissues, three things happen. Sometimes the soft palate in the back of the mouth will collapse at nighttime. That'll interfere with sleeping, and the body then fights, tries to stay awake by releasing stress hormones, which then drive up blood pressure. Another less known factor is that hunger hormone called leptin also increases. This hormone has been shown to create more blood vessels along a very important structure of the brain called the hypothalamus. And that in turn causes elevations of blood pressure. And then finally, a factor that is especially important if you have diabetes is that as a fat proportion increases in your body, there is a higher basal rate of insulin. And it turns out that insulin stimulates the nervous system, which then drives up blood pressure. And then we'll revisit this in a moment too. So several mechanisms that drive hypertension in obesity. So, however, there is some good news. You'll need to post a very modest weight loss, to have a significant drop in blood pressure. So you don't need to have a drastic weight loss in order to have a significant drop in blood pressure. So, for example, for the first 20 pounds of weight loss, you could lose about 10 points off the top number. That's the systolic number. And that's usually the number that we treat blood pressure. And then for every subsequent 20 pound increment that you lose, you could lose another 6 pounds 6 points off your systolic blood pressure. So, admittedly, reducing weight requires changing what you eat, how you exercise, and many other factors. And so the Health Hub has exercise coaches, health coaches that can help you make these changes through cooking classes, group exercise classes. But the big idea is that as we get older, it's very hard to have a lot of vigorous exercise. And so the idea is to focus our effort into reducing the amount of excessive oils and simple sugars that we take in. So it's more about focusing on the calories going in than the calories going out. Exercise is good, but again, it's very hard to maintain high vigor for exercise that will move that. So focusing on the calories going in, it's a more sustainable approach. Now, let's say that you tried everything for years, good faith effort to lose weight, you change your diet, and still your BMI is about 30. In that case, your general doctor could provide you weight loss medications. However, there's a couple of caveats. A lot of these medications, like the semaglutide or Ozempic, Wegovy that you've heard about in Syria, post a rather modest weight loss that is comparable to our cell modification. So these medications should only be targeted by cell modification is completely failed. And also, once you stop taking these medications, weight tends to come back a few months later. So it really boils down to whether or not cell modification was successful. We'll shift gears now and talk about another contributor to high blood pressure. That's excessive alcohol intake. I included this because about 1 in 3 Americans drink alcohol excessively. So now we'll talk a little bit about a couple of mechanisms in which alcohol can increase blood pressure level. So it can affect another structure of the brain, in the brainstem specifically, that governs kind of the calm of that sympathetic nervous system that we talked about previously. So if you can't calm down that part of the nervous system, you can imagine that it'll start acting up again. And so the end result of that is actually your blood pressure increasing. Alcohol also stimulates your adrenal glands to release those stress hormones that we talked about previously, also called adrenaline and cortisol, and those hormones drive up blood pressure. And another interesting aspect in the lungs of alcoholic patients is that there's an enzyme called ACE that's expressed in the lungs that converts an inactive hormone called A1 to an active hormone called A2. So in the lungs of alcoholics, there's a lot of expression of ACE in it, of ACE. So there's more production of the A2 hormone, and the end result is that there's a higher blood pressure in the lungs of alcoholic patients. Another interesting mechanism is that in alcoholics, the contraction of the smooth muscle that goes around the arteries is much stronger and much more long-lived. And I mentioned the mechanism there. I just didn't want to get into the weeds too much. But the end result is that arteries are clenched down and blood pressure tends to stay elevated. And the final mechanism is that there's a very important compound called nitric oxide that helps relax arteries to drive down blood pressure. But alcohol actually interferes in the effect of nitric oxide on the wall of the arteries, so that relaxation doesn't happen, and so blood pressure tends to decline. So there are a couple, and if you have any questions, feel free to provide a question in the chat box, or just raise your hand, or just in something. I'll gladly stop to answer your questions. So what I'd like to impart that up from 1 to 2 drinks per day will increase blood pressure, but anything above it will significantly increase blood pressure. So it's very important to strive to only drink 2 alcoholic drinks or less per day at the very most, and also to avoid what are called nightcaps. Sometimes we have some brandy, let's say, to go to sleep, but it turns out that it might lull you to sleep, but it will end up interfering with sleep, that as we'll talk about later on, then drives blood pressure even higher. So if you are able to reduce the amount of alcohol consumption from, let's say, severe to moderate, or from moderate to occasional, going from those classes has been shown to reduce blood pressure by about 2 or 4 points. As I mentioned before, that might sound very modest, but if you add that in with other interventions, it can really stack up. So that's why I mentioned it in this talk. And then finally, if you are troubled by heavy alcohol drinking, feel free to discuss it with your general physician. There are behavioral therapies and also medical therapies that are very effective, and your health coaches could help you set up the follow-up with the general doctor for that. So we'll switch gears and talk about a very important factor in high blood pressure that I think all of us are somewhat aware of, which is sodium intake. So after decades of large formal clinical studies, these limits have been developed, and they should be followed, and we'll go through the rationale below. But these limits include all of your sources. That's meals, coffee, tea, fruit, everything, snacks. And as you can see, they're very, very small amounts. For example, for sodium, it's only half a teaspoon per day, which is easy to consume in just one meal. And then the other limit is going for roughly 3 orders of potassium. The reason that I mentioned both of these salts is that the sensible approach is to limit the amount of sodium you take in your table salt, but then maximize the amount of potassium that you take in order to compensate for that loss of flavor that goes from having a very low sodium diet. And so you can get potassium from many sources, fruits and vegetables with best, and also salt substitutes like sea salt. Now, there's one caveat that is very important. If you have poor kidney function, you should talk to your doctor before taking on a high potassium diet. So why is it important to limit sodium and favor potassium? It turns out that in Black patients compared to non-Black patients, they have much lower drops in blood pressure when they follow these two constraints. And we'll talk about the DASH diet in a moment. But I also want to bring your attention that it's very easy to go over these limits. I have an example here that just one slice of pepperoni pizza is 1 gram sodium. So just half a pizza, and you're well over your limits. So following a formal meal plan is very important. And so I mentioned that the DASH diet is based on a large study that generated those daily limits that we talked about. And many cookbooks have been developed to limit sodium and favor potassium. And so it takes the guesswork out of cooking. You don't have to calculate or estimate how much potassium you're getting from this banana or this meal or all that. It can get very complicated. So I'll refer you to the public library. I just checked the other night. I have about 24 books regarding the DASH diet and for different levels of expertise and also cooking traditions. Another useful aspect of the DASH diet is that so vegetarian diets will provide even bigger drops in blood pressure, but they're more difficult to follow, especially moving from kind of the standard American diet. So they allow for some consumption of animal proteins, and so it lends itself well to long-term changes in diet. All right, so we'll move on here to physical activity. So I think this is another topic that people doesn't get too emphasized in the physician's office. But so some of the mechanisms that help drop blood pressure with a fair amount of exercises, it increases that amount of nitric oxide that we talked about previously. So that helps relax arteries and drop blood pressure. Interestingly, also, when we exercise, we set off a chain of biochemical reactions that actually increase the number of arteries that are formed, and also the width of those arteries. And so that all works to drive down blood pressure. And then going back to insulin, when we exercise, blood sugar gets shunted into the muscles. And so what ends up happening actually in the bodies of people who exercise consistently is that the pancreas doesn't have to put out a lot of insulin to make sure that glucose gets out of the blood vessels and into the muscles where it belongs. And so as we learned previously, insulin stimulates the nervous system. So if the insulin amount drops, then there's a decrease in blood pressure. You can see a lot of these mechanisms overlap. And so I came by an interesting article that mentioned that about a third of cases of high blood pressure could simply be attributable to a low fitness level, which is quite remarkable. So just exercising, in this study, it showed that patients who go from one level of exercise difficulty to the next um, it can largely treat hypertension, but only with exercise, which is, again, quite remarkable and something that we can all do at home. So here are a few things that you can do at home. Participating in exercise with others is a way to stay motivated. And your health hubs have group-based exercises for different activities and ages. So I would encourage you to contact them to enroll with. You'd like to integrate that into your daily life. Also, walking after meals is very important because it also drives down the amount of insulin and therefore drops blood pressure. And another option in the winter especially is stationary bicycling. They're affordable. They're at Amazon, they cost about $200. And in the wintertime, it's really an excellent way to exercise. And you can just watch a television program or listen to some music. It's something that you can actually integrate for the long term. All right, so a few moments talked about sleep. So briefly, so sleep is divided into two kinds of sleep or types of sleep. One is called REM sleep, which is very deep sleep, and another one is called NREM, which is kind of light sleep. So most of the time we spend in NREM, and so if we are sleep deprived, the body will give up NREM sleep, but it will be very stingy with the REM sleep. So if you're sleep deprived and you're running low on NREM sleep, the body will basically tell your adrenals, make as much stress hormones I need to stay out. And the end result is that blood pressure goes up with those stress hormones. So a similar mechanism as we talked about with other factors. And here are just some general guidelines about good sleep hygiene. So you talked about limiting stimulatory things like exercise and caffeine to the morning, avoiding or at least limiting alcohol, and then making sure that you're not napping during the day is very important. Said that will affect when you sleep and when you wake up. Make sure that your exercise is in the morning rather than the evening, and that your sleeping environment is conducive for good sleeping. So make sure that it isn't cluttered, it's cool at night, and over time you'll be able to associate the bedroom with sleeping rather than doing work or watching television, things like that. Oh. Okay. All right. So the last point that is quite important actually is the involvement of medications in triggering blood pressure increases. So quite often these blood pressure medications have a lot of side effects that are unpleasant. So patients stop taking them, and blood pressure then starts to spike. So beta blockers, these are toprolol, atenolol, and so forth. They can trigger erectile dysfunction in men and fatigue and depression in elderly patients above the age of 65. Then calcium channel blockers like amlodipine or nifedipine, they can trigger leg swelling, which is severe, sometimes causes patients to stop taking medication. Then another class of medications called alpha blockers. These are the medications that act like doxystones and terazosin. These medications relax the arteries, and so blood pressure drops. So if you go without them, the reverse happens, blood pressure starts to increase. And then in a small subset of people who take ACE inhibitors, those are medications like captopril, lisinopril, and suffix pril, they develop a very annoying dry cough. So if you have any of these symptoms, talking to your doctor to get an alternative is more sensible than simply stopping the medication. So next, there are many medications that actually trigger blood pressure. So if a patient is on these medications, even for a short course, whether or not they have high blood pressure, you should still check their blood pressure. Especially some of these medications cause pretty high elevations in blood pressure. And if it's above 120 over 80, then that's an indication to stop them altogether and get the physician involved. So we'll start with oral contraceptives. The higher the estrogen dose, the higher the blood pressure goes. And for chronic pain patients who are on like ibuprofen, naproxen, Lovit, those medications, blood pressure goes up because those medications affect how kidney filters. And so there are two different types of arteries in the kidneys, and the wrong one stays open and the wrong one contracts, and the end result is the kidneys don't feel much pressure. And much like we talked about last time, the kidneys don't feel good blood pressure, they then send a signal out to increase blood pressure. Then other medications, the antidepressants, have also been attributed to increased blood pressure. And so trazodone and nortriptyline, which are tricyclic antidepressants, commonly given for sleep or pain, they can increase blood pressure. And also antidepressants like Prozac, or also called fluoxetine, and Paxil, and sertraline. Next, I think all of you might know that prednisone or steroids can increase blood pressure, and also decongestants that are available over the counter. And finally, a lot of antacids have a great deal of sodium, and so if you're taking them chronically, they also can drive up blood pressure. And then finally, stimulant medications like ADHD medications, Ritalin, Adderall, they can certainly drive up blood pressure. And obviously, just to complete, illicit drug use, cocaine, methamphetamine, drastically rise blood pressure. So I know that I kind of got through this quickly, but I wanted to open up some time for questions. But I just want to bring your attention to the fact that each of these factors has a modest drop in blood pressure, but if you work on all of them, you can have a very significant drop in the blood pressure overall. And making very slow incremental changes is the most sustainable for a lifetime. And making those types of changes is quite difficult, but it's a lot easier when you have a coach that will help you through the lifestyle modification journey. So hopefully that all wasn't too much information, didn't go too fast. So do any of you have any questions?
Always questions. Sometimes it takes a little bit longer to get off mute, but I know there's always questions. So thank you. That was a great presentation.
Hello. I don't know if can you hear me?
We can hear you. Yes.
Oh, okay. Because my reason why I didn't answer earlier, I thought my Zoom one wasn't acting correctly. Thank you, doctor, for your information. It's very informative to me because I'm one of those that actually have to deal with blood pressure every day. I do take medication for it. and I'm trying to do some things, but I see a lot of things that I am not doing very well. And then as far as getting my recommended sleep, and I do exercise, but I think I can ramp that up a little bit. Getting sodium out of my diet, I have found out that I am not keeping up with it if I eat out. So I try to prepare my own meals, but when I'm eating out, I tend to go over. So my question is for you is that would taking your blood pressure medication late at night affect your body?
So as long as it's every 24 hours or every 12 hours, however your particular medication is, it should make a large difference. But
Okay.
so perhaps, generally when we go to sleep, we're not actively digesting. So I could imagine some medications might not fully dissolve. So it's best to take it in the morning with a meal to make sure that it gets fully dissolved and absorbed.
Okay. Thank you.
Hello, doctor. I have a question about you made note of amlodipine as one of the medications, and you showed that leg swelling is one of the side effects. I guess about a month ago, I was told that I needed to take amlodipine as opposed to a diuretic. So I was initially given a 10 milligram dose, which after about 3 days did cause some significant swelling in my ankles. So I called the doctor. We reduced the dosage to 5 milligrams. There is still some swelling. So would you recommend, and I do know I read that there's also a 2.5, but I'm wondering if that would even effectively manage the blood pressure.
So it would boil down to what other blood pressure medications your doctor tried in the past. If you're basically down to only amlodipine, you tried other medications that didn't work out, or you need several of them, and you also need on top of all of that amlodipine, and you might basically retract taking the amlodipine. But if there are alternatives, you can talk to your doctor about that. Another approach is to wear compressive stockings, and also to really think about, how if you're sticking to that sodium and potassium, those constraints, it's very easy to go over half teaspoon. It's a tiny amount. It just fits, at the bottom of your hand. So those are a couple factors that you can think about. So if amlodipine is like one of your last options, then you just have to find ways to deal with the side effects of compressive stockings and also reducing sodium intake. But if you have other alternatives, then it'd be better just to tell your doctor that you need another medication, because like swelling over time, it will actually damage your veins. So it's not the entirely benign side effect that it has consequences years into therapy.
Okay. You mentioned the compression stockings, would that sort of have to alleviate that impact on the veins?
Certainly. So the idea is, as the leg is compressed, it forces blood back into the veins. And also another aspect of the veins is that basically veins are like, they have these one-way valves. So you can think of my thumbs as the one-way valves. So if blood pressure is blood is being moved up, those valves will stay intact. But if you don't have compressive stockings, that blood isn't getting moved up, and so there's pooling, and eventually those valves become incompetent, and so blood is more likely to been pooled. So using compressive stockings will help the health of your veins.
Okay, so not using them will make the swelling will cause progressively more damage to the vessels.
Yeah, after it will take several years, but I currently believe now in a pound of prevention is an ounce of cure, and it's very important to just avoid problems before they start. So, but the main thing will be whether or not the elevation is really critical for you, or if you have some other alternatives.
Okay. All right. Okay. Another question I have in regard to sleep, because I also have difficulty with the sleeping. So and you read different things about how much sleep you should get, and is it 7 hours, 8 hours, or is it an individual issue?
So the science shows consistently between 7 and 9 hours is optimal for everybody. I think that some people say that they can get by with 5 hours and they're functional, but it turns out that the body actually needs at least 7 hours to conduct the basis of sleep, which is something that was discovered about 15 years ago. And actually, the physician for the physiologist that discovered this earned the Nobel Prize in medicine. Basically, when we sleep, there is a mechanism that starts the brain and goes all the way back to the spinal cord, and you can track the flow of what's called cerebrospinal fluid. You can think of it as like a sleeping mechanism that removes what are called neurotransmitters. So this is basically the metabolites that build up from thinking. They build up and they have to be removed from the brain, from the central nervous system. And that process takes about 7 hours at least. So if you're not getting 7 hours, those metabolites will build up. As those metabolites build up, they damage nervous tissue. And that's why people who are chronically sleep deprived, they're not sharp, don't feel sharp, they'll have chronic headaches, they will feel kind of emotionally labile. That just means that they feel like they're kind of going through ups and downs of emotions throughout the day. And that's all basically symptoms that the nervous tissue is just not working properly. So it's very, I think sleep really is fundamental, like air, like water, like food. It's not important.
Final question. If you get the 7 hours, does it have to be continuous? Because I think I get 7, but I fall asleep. I might sleep for an hour and a half, 2 hours, and then I wake up. And then I go back to sleep. And now the second time, I'll probably sleep 5 hours, 4 or 5 hours. So when I piece it together.
Right. So you maybe get that 7 hours, but if you break up your sleep, statistically, you will be more likely to wake up during those periods when you're in REM sleep, that would be deep sleep. And when that happens, that's a big no-no. You can really affect your sleep quality that way. I mean, when you wake up, there's no way to know, if you wake up, generally you'll wake up at the non-REM, the light sleep, but sometimes you might wake up during deep sleep.
Yeah.
But overall, it's much better to get a good 7 hours of sleep. And also, problems with maintaining sleep might suggest that there are other things going on. Maybe you might have anxiety, maybe untreated depression. And it's actually good to kind of listen to your body because it might not be just about popping the melatonin. There might be other things going on. So really, you should work with your physician to ensure that you arrive to a place where you're getting a full 7 hours of sleep, or at least 7 hours. 8 hours is better, and that your sleep is restored. So in the morning, you're well rested, you're clear-headed, and you really don't feel tired throughout the day. Those should be the goals, and your doctor will be able to kind of look into that and see what other factors might be contributing to insomnia.
Okay. All right. Thank you. Thank you.
Somebody else has their hand raised, and I don't know who it is because it has my name. So
right.
Go ahead with the next question, whoever
It's
had it.
me, Jan, and I was just wondering because I have trouble with my kidneys, and so I I get maybe 3 hours of sleep, and then I have to get up because I got to go to the bathroom. So, how can I extend my sleep without doing more damage to my kidneys?
Well, so when you wake up, is it generally because you have to urinate? Or
Yes.
Okay. All right. So this is a frequent follow-up I have with my patients. I tell patients to make sure that they avoid drinking fluids past dinner time. And so I tell patients to shift their fluid intake earlier during the day. And so that's one big factor that will produce less urine at nighttime. It might seem kind of low tech, but it generally addresses the production of urine pretty well for about half of at least my patients. Is that something you tried in the past?
Yes. How late? If I'm asleep at 11:00, and then I'm awake at 12:30, and then I'm awake at 3, and then I'm awake at 4:30, and then just
So when do you stop drinking fluids?
9 or so.
Okay, so I think it'd be a very good idea to shift that window of fluids, move it back another 3 hours. So you should start drinking fluids as soon as you wake up early in the morning. Stop roughly at about 6 or 7 o'clock. And so basically, you'll spend the evening producing your last bit of urine, and then you really won't produce much in the evening. But if you're drinking fluids into the 9 o'clock, 10 o'clock hour, that will catch up with you. So I think that's something that you could use, and it might make quite a difference. Another issue is that are you on a diuretic medication?
No.
No, good. Okay. And let's see. Do you have diabetes?
No.
Okay. So in your case, I think simply stopping fluids past 6 o'clock or dinner time would be the best intervention. It won't fully take care of it, but it could be enough that you could then report back to your doctor, and that your doctor could then check your medications if they are a cause, or if your production frequency is simply an unavoidable part of your particular chronic kidney disease. But I suspect that you'll have a lot of relief by just stopping fluids past 6 o'clock.
Okay. Thank you.
Sure.
I have a question.
Sure, go for it.
Okay, it's about the caffeine. I don't drink coffee in the evening too much, but sometimes I do. But I'm concerned about the soft drinks that have caffeine in it. So you should not, as I was reading in the afternoon, you should not drink a lot of caffeine.
Yes, in general. So caffeine has half-life of about, I think, 15 hours. So that means that after 15 hours, you still have half of the caffeine in your body. So if you drink coffee or caffeine in the morning, you'll still have some caffeine in your system by bedtime, but it's a lot better than the full amount. You'll have half is better than all of it. So really, like avoiding caffeine past like 9 o'clock is a very good idea to avoid insomnia. So I know it's unavoidable. I mean, I'm useless without my morning espresso. But that's all I take. I have it at 6 o'clock, and I'm able to be productive all day. But then by the time 9 o'clock rolls around, then I start winding down. But if I have caffeine past 9 o'clock, I don't sleep. So I just keep that to the morning.
Okay, thank you.
Sure.
Dr. Tamar, thank you so much for joining us tonight. We really appreciate your time. I know you've worked on this presentation. It had to take a little bit of time to put together. So we are grateful for your help. I'm grateful for your input and your knowledge and everything. So
we hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.